Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Hello, I'm Dr. Colin Crowe, Assistant Professor of Family and Community Medicine at Case Western Reserve University, a family medicine physician at Metro Health, and podcast lead for Cardio's Team Best Practices. In this podcast, we'll review the risk factors, diagnosis, and treatment approaches for hypertension in the pediatric population. Understanding the pathophysiology of pediatric hypertension and its risk factors is critical for preventing complications and addressing disparities in vulnerable populations. I'm here with Dr. Ryan Farrell, a pediatric endocrinologist at Rainbow Babies and Children's Hospital in Cleveland, Ohio. Dr. Farrell has an interest in pediatric obesity, including its pathophysiology and complications. He serves as an associate professor of pediatrics at Case Western Reserve University. Welcome, Ryan.
Thanks for having me. I'm looking forward to the discussion.
So let's set the stage for our listeners here. We'll be focusing on pediatric patients today, so ages 18 and under. I know pediatricians say all the time that kids aren't just little adults. So our youngest patients are getting their very own podcast today. Now, when it comes to pediatric hypertension, can you start by defining that for us?
Yeah, sure. So pediatric hypertension is defined as elevated blood pressures that are persistently above the 95th percentile for a child's age, sex, and height. Diagnosis of pediatric hypertension has actually really important implications for health outcomes, both during childhood as well as later in adulthood.
How common is hypertension in kids? And are there risk factors that we need to know about?
The overall prevalence of hypertension in children is about 4%, but it's important to show that there's a significant rise to 10 to 11% among 18-year-olds. The risk also increases, particularly with puberty, and males have a much higher predisposition, upwards of 3 to 4 times that of females. And then certain medical conditions, things like type 1 or type 2 diabetes, obesity, and sleep apnea are all strongly associated with the development of pediatric hypertension as well. And then interestingly, prematurity or being small for gestational age, or SGA, may impair nephron development, predisposing those children to hypertension later on in life.
That's interesting. It would be easy to think SGA babies, small for gestational age babies, or former preemies wouldn't be affected, but of course it's more complicated than that. So as we know, identifying risk factors and populations at higher risk is critical in addressing healthcare disparities. What kinds of disparities are important to recognize?
Geographic and demographic factors all play a role in hypertension prevalence. We see higher rates observed in urban areas and regions with elevated obesity rates. And then on top of that, race and ethnicity are significant factors as well, with Black and Hispanic children experiencing higher prevalence compared to that of their white peers.
Often we see that social and environmental factors drive these health disparities. Can you tell us a bit more about that?
Sure. So, families and social determinants of health influence things like our dietary habits, which can contribute to hypertension risk, including things like high intake of sodium and sugar-sweetened beverages. And then chronic stress and environmental exposures are also really big contributors, especially adverse childhood experiences, or ACEs. In fact, studies show that children exposed to 4 or more ACEs have higher blood pressure compared to their controls. And then there's these specific ACE subcategories, things like household substance use and parental divorce and household mental illness. Those show particular importance. And then environmental factors, things like tobacco smoke exposure and air pollution, these have all been strongly linked to pediatric hypertension as well, even when you account for all the potential confounders in the rest of the environment.
Yeah. Well, now that we have a little background on the overall risk of pediatric hypertension, what is the evidence that intervention really matters at this young age?
That's a good question. So, the early cardiovascular impacts of hypertension are profound. There's subclinical changes that are already detectable in children. So things like atherosclerosis, things like increased carotid intima media thickness, or CIMT, and greater arterial stiffness. All of these are associated with cardiovascular disease in adulthood. And then notably 38 to 46% of adolescents with primary hypertension will show elevated CIMT at diagnosis. These findings align with the concept of early vascular aging and early biological maturation. So where we're seeing hypertensive children demonstrating this kind of biologic age advancement upwards of 4 or 5 years advanced compared to their normotensive peers. Interventions addressing hypertension also can reverse this early vascular aging, with improvements observed as early as 6 weeks into lifestyle and dietary interventions, and those benefits can be sustained over a long period of time too.
Wow, that is really something. 40% of kids with hypertension show evidence of early vascular aging at the time of first diagnosis. Wow. Now that we understand the importance of pediatric hypertension, how do we screen for it?
Good. So during childhood, blood pressure gradually increases over time to support, kids' normal growth and development. So the normal range, so again, like the 5th to 95th percentile for both systolic and diastolic blood pressure in children is stratified based on, the age of the child as well as the sex and their height. So as in adults, there are stages of hypertension in pediatric patients. So for children age 1 to under 13, we define elevated blood pressure as blood pressure in the 90 to 95th percentile. We used to call that prehypertension. Stage 1 hypertension refers to greater than the 95th percentile, but less than the 95th percentile plus 12, or absolute values of 130 over 80 to 139 over 89. So whichever of those two values is going to be lower. And then stage 2 hypertension is greater than the 95th percentile plus 12, or 140 over 90 and above, whichever one is lower. So those different stages can be a little bit easier to understand visually than just hearing it. So we will also give you a link to a table of these different criteria in our show notes.
Okay, so that's for kids age 1 to under 13. So for children over 13, it's the same as it would be for adults?
Yeah, so for children age 13 and up, it's going to look, pretty familiar to those caring for adults. So again, elevated blood pressure, we would usually call 120 over 80 to 129 over 80, somewhere in that range. For stage 1, 130 over 80 to 139 over 89. And then stage 2, we would say over 140 over 90. The American Academy of Pediatrics specifies that the diagnosis of hypertension is based upon meeting that criteria at least over 3 different visits. So for children and adolescents, blood pressure assessments are recommended at every annual pediatric well child visit, routinely starting at age 3 years. And then pediatric patients that have additional risk factors for hypertension really should be assessed at every single health encounter.
It makes a lot of sense to start at age 3. As we all know, toddlers are pretty wiggly, and the younger kids might be pretty scared by the equipment. I'm sure all of our listeners know it's not easy to get a reliable measurement in the office. So, what are some pointers for this you can share with our listeners?
Yeah, so if the initial blood pressure is over the 90th percentile, then 2 additional blood pressures really should be obtained at the same visit and then sort of average those blood pressures together to determine the blood pressure category. Beyond that, in office blood pressure monitoring in children as in adults really requires the use of equipment that's well maintained and calibrated for the manufacturer specifications. We have to make sure that there's proper selection of the cuff size, particularly in pediatric patients. And we got to make sure that the patient is well positioned and carefully timing the assessment after a period of rest specifically. And so if we're seeing oscillometric devices, again, like calibrated automated machines that are being used in office settings, they really should be validated in the pediatric population. There's standard procedures in the pediatric population that have similarities to adults, but there's some important aspects that we should highlight. So first, the child and the medical provider should be calm and quiet and really not talking for at least 3 to 5 minutes before the measurement is taken. Again, that's sometimes hard to do in a very busy office setting, but that should be done if possible. We should emphasize that there is this concept of what we call white coat hypertension, which is much more common among children. So again, up to half of children evaluated for elevated office blood pressures will have some level of white coat hypertension. And even in adults, 15 to 30% may have white coat hypertension. But it's important to know, particularly with children that have white coat hypertension, that actually may be a risk factor for abnormal blood pressure in the future. And children with suspected white coat hypertension actually should also undergo ambulatory blood pressure monitoring within the next couple of years after that diagnosis is made. And then on top of that, the blood pressure cuff size, again, is determined really based on the width and the length of the bladder. Bladder length really should be 80 to 100% of the circumference of the arm, and the bladder width should be at least 40% of the arm circumference. So children and adolescents with obesity in particular will need special attention to ensure that we have the proper cuff size. And that necessitates, obviously, that offices have all the different ranges of sizes of blood pressure cuffs as well, including thigh cuffs. And then particularly in children, the correct size cuff needs to be ensured, given, again, that there's just various sizes of children that are going to come in through the office on a regular basis.
Yeah, that makes a lot of sense. You mentioned out-of-office blood pressure measurements or ambulatory blood pressure measurements. Can you tell us more about the role that these have in pediatrics?
Of course, yeah. So, acknowledging, of course, the challenges of in-office blood pressure screening with a potentially very anxious child, and again, like limited time for visits and missed visits and higher likelihood of this presence of white coat hypertension, there's this important thought of having ambulatory blood pressure monitoring being utilized to, obtain additional sort of real-world screening information. It also allows for measuring patterns of blood pressure responses, not just during the day, but overnight. And sometimes that has meaningful impacts, in sort of prognostications for kids as well. And then even being able to measure blood pressure responses during exercise. So all this could be pretty helpful information. But in some situations, ambulatory blood pressure monitoring may not be readily available. And so in that setting, people often have to think about sort of home blood pressure monitors and if those are accurate. There is evidence that home blood pressure monitoring can be reliable and accurate in children. But again, the caveat, as we kind of stated previously, is that the correct cuff size really needs to be used and the machine really needs to be validated in children. That's the hard part, is that there's really only a few machines out there that are validated for children. And so on top of that, there's somewhat limited access to the different cuff sizes for home blood pressure monitoring. To ultimately determine if a machine is validated, you can check on the Stride BP website. We can include that link in our show notes. So outside of having the right cuff in the machine, we also don't have wonderful data to tell us when or how often children should be performing home monitoring outside of the office setting. So for those reasons, the American Academy of Pediatrics does not routinely recommend home monitors be used to diagnose hypertension or white coat hypertension. But again, it still may be useful for monitoring children that already have a diagnosis of hypertension.
Sure. Okay, so we've made the diagnosis of hypertension in a pediatric patient. Now what? What do we do next?
So first off, we should emphasize again that pediatric hypertension can be due both to primary as well as secondary causes. So importantly, in children, at least half of all children with hypertension may actually have a secondary cause, including kidney, hormonal, cardiac, or medication-related high blood pressure. So this is much more likely in younger individuals, so specifically those under the age of 15 years old, and then early involvement of pediatric subspecialists, whether it be in particular probably a pediatric nephrologist, is really incredibly important to ensure that another cause of hypertension is not identified. And then for treatment of primary hypertension, again, lifestyle modifications or non-pharmacologic treatment are usually the first line interventions and are recommended for all youth with hypertension. So the dietary approaches to stop hypertension are the DASH diet, which prioritizes reducing sodium intake and increasing whole grains and low-fat dairy and fruits and vegetables, has been well established for lowering blood pressure in children. Cardio, again, has some great information about the DASH diet, which, again, we can link to that in our show notes. There's a meta-analysis that was done of 18 observational experimental studies that show that every gram of additional dietary sodium intake actually increased systolic blood pressure by 0.8 and diastolic blood pressure by 0.7 in children and adolescents, while sodium reduction interventions, again, can also lower systolic and diastolic blood pressure by 0.6 and 1.2, respectively. Increasing physical activity also improves blood pressure levels in pediatric patients, particularly when you're combining it with dietary and behavioral interventions, things like counseling as an example. We have good data that shows that diastolic blood pressure improves even with just school-based physical activity. And then, weight management in obese and overweight children is also going to be very essential for reducing pediatric hypertension. And there's been some studies that have shown that systolic and diastolic blood pressure reductions are occurring in the setting of weight loss. So those programs that are available sort of in your local area that focus on weight management and nutrition counseling, those referrals are very important to consider as well.
Yeah, absolutely. Okay, so we've started with DASH diet, we've started with referrals, increasing physical activity, thinking about weight loss. When should we start pharmacologic treatment?
Yeah. So pharmacologic treatment for pediatric hypertension requires very careful consideration, and it's initially with low dose monotherapy. And so the indications for pharmacologic intervention will include either ineffectiveness of lifestyle modifications, or if we've reached stage 2 hypertension without any clearly modifiable risk factors like obesity, or any patient that has symptomatic hypertension, we should certainly consider starting pharmacologic therapy as well. If we're also seeing things like target organ damage, things like left ventricular hypertrophy, or in any patient that has hypertension along with things like chronic kidney disease or diabetes mellitus, those would all be indications for starting a monotherapy for hypertension. The first line drug classes in pediatric hypertension usually include ACE inhibitors or angiotensin receptor blockers or ARBs, diuretics, and then long-acting calcium channel blockers. Beta blockers are usually not recommended as first-line pharmacotherapy in children. If monotherapy titrated to the maximum dose fails to achieve blood pressure control, then we think about starting to add a second medication. And in particular, we should have some level of caution in adolescent females that are using ACE inhibitors or ARBs due to that fetotoxicity. Pediatric hypertension should be treated to reduce blood pressure to whichever one is lower, either the 90th percentile for age or less than 130/80. And then for children with hypertension and diabetes, again, an ACE inhibitor or ARB is particularly our first line medication. In pediatric hypertension with chronic kidney disease, we might use a lower blood pressure target. The mean 24-hour arterial pressure really should be reduced to less than the 50th percentile by ambulatory blood pressure monitoring. ACE inhibitors or ARBs, again, are the first-line medications in these cases as well. And then treatment monitoring is really essential. So pediatric hypertension patients should be seen every 4 to 6 weeks until the blood pressure treatment target is achieved. And then once we've sort of hit our goal, every 3 or 4 months, we should be following up with these patients. And unlike treatment-resistant hypertension in adults, it's not clear if there truly is such a similar form in children of this kind of treatment-resistant hypertension. But for pediatric hypertension that's uncontrolled on 2 or more medications, we start to use this kind of term of apparent resistance hypertension of childhood. So that's sort of, kind of up for debate still at this point.
Yeah, really interesting. And we've really seen some key differences here in pediatric patients, which might be a change from how those of us who treat adults, what we might be familiar with. And as we said earlier, kids aren't just little adults. Establishing the diagnosis is different for sure with those age-based and percentile cutoffs, and our adult providers might want to listen to that part again just to get more familiar. Another key takeaway for me is that up to half of kids will have secondary hypertension, and a cause should be searched for with the assistance of a specialist if that's available. And that's very different than the adult prevalence of secondary hypertension, which is about 5 to 10%.
Yeah, excellent. Yeah. So we can conclude again that the recognition and treatment of hypertension is really critical in children. Identifying pediatric hypertension obviously requires exploration of important secondary causes, like you've kind of mentioned, kidney, cardiovascular, or hormonal conditions. And the thresholds of diagnosis for hypertension are going to vary, as we kind of talked about, based off of age, gender, and height. And the treatment of hypertension has a lot of important implications for both short-term and long-term health and risk of cardiovascular disease as you enter into adulthood as well.
Yeah. Dr. Farrell, thank you so much for joining me today, and thank you so much for sharing your expertise.
Oh, thanks for having me.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.